Hi everyone, João Quirapena here, and welcome to the next webinar. The purpose of the discussion today is to introduce you to our next guest speaker, Dr. Bart van den Bemt, is outpatient pharmacist, clinical pharmacologist, and senior clinical scientist at the Departments of Pharmacy in the Sint Maartenskliniek and Radboud University Medical Center. Bart earned his MSc in pharmacy and his pharmacist degree at the University of Utrecht. Subsequently, he completed his postgraduate qualification as a community pharmacist. After several years of working in community pharmacy, Bart decided to broaden his experience and started to work as a pharmaceutical care developer for a franchise formula for community pharmacists. Since 2003, Bart is working at Sint Maartenskliniek. Bart is also chair of the ESCP Special Interest Group on Medication Adherence. He's also vice president of the Dutch Association of Hospital Pharmacists, president of the European Society for Clinical Pharmacists, and also treasurer of the DRM Foundation on pharmaceutical care for patients treated with anticoagulants. Dr. Bart, thank you very much for joining us. I appreciate your time.
Thank you very much for this introduction, and I look forward to have this webinar together with you.
You're welcome. So the purpose of the conversation today is to explore in a little greater detail the application of pharmacoeconomics in the Netherlands, and I thought for the benefit of the listeners to start with a better understanding of the structure and the delivery of the healthcare system in the Netherlands. How is access to medicine regulated in the Netherlands?
In the Netherlands, we have an authority which looks at the drug and looks at their effectiveness and also at the safety of the drug. For relatively small medication, it's the Dutch authority on medication evaluation will do this evaluation. The more expensive and more international drugs are centrally registered by the European Medication Authorization, the EMA, and they look at the effectiveness and the safety of the drug. And if there's a positive balance between the effectiveness and safety, they say this drug may introduce to market. However, when a drug is on the market, it's not definitely that it's also reimbursed. So the next step is that it should be looked at whether it's reimbursed or not. So for expensive medication in the Netherlands, we have a specific office in the Dutch authorities of health who judge the drug about what do they have value for money or not. Okay. And if there is value for money, there is even what we call a lock, and the expensive medication should wait in the lock because there's first a negotiation between the Dutch health authorities and the pharmaceutical industry about the price. Okay. And if there's an agreement on the price, this drug may enter the market. That's for the expensive drugs. And for the cheaper drugs, we have a so-called clustering system. All drugs with a little bit the same chemical structure and the same indication are clustered within one cluster therapeutical class. And then the drug should receive the same price as the medical class which already exists, and so the price of that drug is determined. So we have two systems: a central system by the government for the expensive drugs with a so-called lock, and we have a system of clusters, and drugs are authorized. And the drugs are all authorized, and there's a permission to bring it to the market. It will be clustered with medication with the same therapeutical class.
Okay. So for expensive medicines, it is the more of an HTA type of negotiation and an evaluation, whereas with the cheaper drugs, the clustering system that you mentioned is kind of a reference. A therapeutic referencing, reference pricing that takes place within that area.
Yeah, and okay. I must admit that for the expensive drugs, there is a kind of a EGA assessment, but also just negotiating about the price, because you can still discuss about are these drugs, should they really be that expensive? But that's not solved in our system yet. It's only now about reducing the price.
Okay. Okay. So the other question was how is medicine price regulated, and you've answered partly the question of talking about the lock for expensive medicines and the therapeutic reference pricing on one side. Would you mind maybe describing a little greater detail that the involvement of pharmacists in that HTA process and that price negotiation, if they are involved at all?
Yes, of course. In fact, I think you have to separate 4 types of drugs and 4 life phases of a drug. So in the first phase of a drug, when it's a monopoly drug, so there are no other drugs with the same indication, it's the pharmaceutical industry who can determine the price, and only the Dutch government has influence on the price, because when a doctor asks for a drug and there's just one drug in authorized for that indication, as pharmacists you can hardly negotiate with the pharmaceutical industry, because then they say you will not receive the drug and the patient will not be treated. So in the first phase of the drug, there's only room for the health authorities. At the moment of market entrance, they have they can say you can't enter the market if your price is not enough. However, when a second drug is entered in the market with the same therapeutic class, and it's and you can compare these drugs with respect to their effectiveness and their adverse events, as pharmacists you have a chance, a very nice chance. And we indeed in my hospital we use this very much, that we make a so-called preference policy with our physicians. So we say to our physicians, the first question is, do you really think that these drugs are equal? Because it's the medication, the pharmacotherapeutical equivalence should be assured. And then the physician says, yes, we think these drugs are equal. We then ask the physicians, are you okay with the fact that we tell to the pharmaceutical industry that they can receive 80% or more of the first prescriptions of a drug, and if they are willing to be a partner for us. So we say to them, we guarantee that more than 80% of the first prescriptions will be your drug. And of course, we ask them in return a specific price for that specific position.
Okay.
So
does this second phase, it sounds like is there a specific name for that second phase?
Thank you for questioning. Yes. That phase is the oligopoly. So oligo from the Greek, which means a little bit. So there is a little bit market, and the market is between drugs of the same therapeutic class, but there are no biosimilars and no generic drugs present yet. I can give you an example. Probably you have heard from the anti-TNF drugs in rheumatoid arthritis. 15 years ago, we had only infliximab. At that moment, the manufacturer of infliximab could ask the price he wants, because it was the only product in the market, and it's a really good drug. So patients with rheumatoid arthritis indeed ask for it, prescribers ask for it. So we have to deliver the drug for the price the manufacturer wants to have. However, shortly thereafter, new products entered the market, like etanercept and adalimumab.
Yeah.
And etanercept, infliximab, adalimumab are roughly have the same effectiveness and also the same safety profile. So we decided with our rheumatologist, can we say that these drugs are equal, and can we then promise the manufacturer that we as Maartenskliniek do all for more than 80% of the first prescriptions will be one of these 3 drugs. And then we asked the 3 manufacturers of infliximab, etanercept, and adalimumab for a price for that position.
Okay.
And we have, of course, to illustrate them to the manufacturers that really more than 80% of the drugs, of the first prescriptions, are the drugs of that manufacturer. and then you see that the price of the drug will dramatically decrease.
Okay. Okay.
And so that really involves the pharmacist in that position.
So in this phase, the oligopoly phase, there's no biosimilars yet in the market. These are still innovator products, but now a few of them in the same therapeutic class.
Indeed.
Okay.
And that brings us to the third phase, when biosimilars or the first generic drugs are entering the market.
Okay.
And also at that moment, there's an important role, I think, for the pharmacist, because the introduction of generic drugs, or even more complicated, the biosimilar drugs, can be done very well by the pharmacist together with the prescriber. Here in our hospital, a lot of experience with it, that if you work together as a prescriber and pharmacist, you can implement biosimilar drugs very well. We have, for example, 96% of our patients switched from an originator to a biosimilar drug, and then you have reduced the price by introducing the biosimilars. And that's the third phase. And in the fourth phase, then there are also more biosimilar manufacturers, and then the price will be less influenced by the pharmacist, because in the Netherlands then the healthcare insurance companies start to make their own preference policy, that they say we have a deal with a specific generic manufacturer, and you should deliver always the same generic drug from the manufacturer we have a contract with.
Okay.
So in the end, we have 4 phases. The monopoly, which is directed by the Ministry of Health. Oligopoly, which can be influenced by the pharmacist. The introduction of the first biological or biosimilar drug. So the introduction of the first biosimilar drug or generic drug, which can be influenced by the pharmacist. And the fourth phase is mostly influenced in the Netherlands by the healthcare insurance companies, because then you only have generic drugs.
Okay, that's I understand it. Oligopoly phase, that the producer will be provided a guaranteed market of 80% of first prescriptions. Is this for all hospitals in the Netherlands, or would this just be done at a per hospital level, depending on the budgets that are available in the hospitals?
It depends on how large you are as a hospital. If you are a large hospital, you can allow it to do it yourself, because then you have enough volume to have negotiations with the pharmaceutical industries. If you have less volume, then in the Netherlands we have groups of pharmacists together who do the buyings.
Okay.
And sometimes they together decide to have a preference policy, but that's a little bit harder compared to my situation, where as I am in a large hospital, I can do it for myself. If you are in a group of, for example, 8 hospitals in a buying group, in all the 8 hospitals, they should introduce the same preferred biological or expensive drug. That's a little bit harder. But still, you group the volume of your buyings, and that makes that the price will lower.
Absolutely. So from a practical perspective, how would patients get access to their medicines? Are they going in an inpatient and outpatient environment? Outpatient, is it mostly community pharmacies that patients will get their medicines, and are there co-pays?
Yes, that's an interesting question. About 10 years ago, we had a very simple situation, that we have community pharmacists who deliver the medication to the patient going to the GP, or also for the outpatients. And in hospitals, we only have hospital pharmacies delivering to hospitals. About 10, 15 years ago, the outpatient clinics were introduced in the Dutch hospitals. And a few years later, it was decided that all the expensive drugs should only be dispensed by the outpatient or the hospital pharmacy. And the argument, and I'm very pro for the argument, is that if expensive drugs are in the budget of the hospital, they are more likely to influence also the price, but also the volume of the drug.
Okay.
So when a hospital is responsible for the expensive drugs, and they are now, they look far more carefully at the buying prices, but also they are looking far more carefully at the volume of the drugs. For example, in the Netherlands, when it was obliged that the expensive drugs can only be dispensed by the hospitals, we started with studies to research if a lower dose, for example, is possible. Because then, if you give a lower dose with the same effectiveness, you earn money for the hospital.
Absolutely.
And of course, the requirement is that the quality should be the same. But now you have the situation that with the same quality, people are more keen to reduce the price.
Okay, I understand. And the medicines that patients would obtain, both in outpatients and an inpatient environment, would be fully paid by the Dutch government, by the Ministry of Health, right?
Yes, it is more than 95% of the drugs in the Netherlands are fully reimbursed. There are two exceptions, roughly. The first one is that for over-the-counter medication, paracetamol, low-dose ibuprofen, obstipation drugs, these drugs are not reimbursed by the insurance companies. That's one. And the second one is that in the Netherlands we have a so-called own risk. I don't know if you know what I mean. It means that, for example, the first 500 euros should the patient pay by themselves. And if you have more expenses than 500 euros on your healthcare cost, the healthcare insurance company will pay it for you.
Okay. And so it would be kind of like a savings account, and then once you've reached that threshold, then the government will continue paying after that threshold.
Yeah.
Okay.
And in fact, we have a layer between. This is not the government. We have so-called healthcare insurance companies.
Okay.
So these companies are paid partly by the government, but also by patients themselves. Every inhabitant of the Netherlands is obliged to have an assurance with a healthcare insurance company.
Okay, got it. Moving on to the next theme, which is the application of pharmacoeconomics. You've already mentioned that for expensive medicines, there's the LOC, which aims to investigate the value for money question and also do the price negotiation. What is the name of the agency, and is this the only government agency that is responsible for the health technology assessment?
From a governmental point of view, this is the only one, the so-called SIN, and they evaluate the cost effectiveness of a drug. And when SIN gives a positive advice, then it goes to the so-called LOC, if it's an expensive drug. And in the period the drug is in LOC, it can be tolerated in the market. Then the negotiations will start between the government and the manufacturer in order to get a good price. And I have to admit that there are two reasons for that LOC. The first one is to indeed have negotiations and to have a lower price. And the second one is also a little bit political, because there is then a waiting period which also reduces the time of spending. So it's a little bit of a retardation of the entrance of a drug.
Okay. All right. So just slowing down its entrance.
Yes.
Would this lock period also be used for generating additional evidence where maybe the clinical trials were in very small patient populations, or for example, or maybe SIM is requesting that there be local Dutch data be used in the pharmacoeconomic evaluations? Would those be kind of areas that would be addressed during this lock period?
Mostly it's not addressed. It will be addressed in the period that it should be done. But the lock period is, for example, 3 to 6 months. So it's not enough for good evaluations. But what they then sometimes do is that we accept the drug for example, 4 years, and after 4 years, there should be an evaluation of an HTA evaluation of the cost effectiveness of the drug. However, there's a problem on that. The problem is that once a drug is tolerated on the market, it's hard to after 4 years to stop the drug in the market because patients are on it, and it's hard then to say to patients, unfortunately, we will not reimburse it anymore because we show that it's not cost effective. So that makes it a little bit hard.
Okay, understand. The second question on the slide, how are its decisions used to guide funding decisions? I think we've already covered in what you've just provided an overview of the lock period, the price negotiation, and the political component. But the third question is, are there pharmacoeconomic guidelines that are used in the Netherlands to facilitate this decision making?
We have, of course, a document which states that, and I said by heart, that about the price of the quality. So there's a discussion what price of quality is acceptable. And for example, we say that if the price for quality is 60,000 euros or lower, a medication can enter the market. If not, it's too expensive. But I must admit that there is a difference between the real price, and the price which is in the end paid by the government. There's a negotiation on that. So there are some guidelines and also standardized methods to evaluate the cost effectiveness of a drug. But I also have to admit that it's a lot of political issues are in it. And that's, for example, we recently had a discussion about a drug for cystic fibrosis, which was, according to the Dutch evaluation, the price evaluation authorities, was too expensive. And so, in the beginning, the Ministry of Health said we will not tolerate this drug because it's too expensive. But then there was a huge rumor, and patients with cystic fibrosis were introduced on the television. And you see that the pharmaceutical industry is then very smart in doing marketing, and they can always present a patient, and the best is a very young patient with a disease. And in talking shows on the television, it said it's a shame that this patient will not receive his medication. Sometimes they even forget to say that it's a shame that pharmaceutical industries will ask people to pay more than 100,000 euros for it. But that's the discussion. So therefore, in the end, it's always also a political discussion that somebody should be brave and say, we really don't tolerate that drugs are that expensive, because if you spend for drug, for example, 100,000 euros on a drug, and you can also pay nurses for this drug and so on.
Okay, understand. The 60,000 euro price per quality that you mentioned, in your prior experience, what proportion of drugs would have come under this threshold, and what proportion have not?
It's hard to say. It's hard to say. I think that because also the calculation of quality is not always that clear. But roughly, I think that 80% will success and 20 not. But that's a very rough estimation.
Okay. All right. No, fair enough. And the pharmacoeconomic guidelines in the Netherlands, you've already mentioned this period during the lock period, saying that after all the conversation has taken place, the price negotiation, the political period to kind of slow the introduction of the newer medicine is. You mentioned that there would be a period of 4 years that the medicine would be put onto the market. Is this the idea of sustainable financing for that innovative medicine during that 4 years, and then maybe another 4 years afterwards or 4 years beyond that. So the point is patients would never be out of therapy because there's the that would be addressed through the lock period.
Yes, but it depends also on the severity of the disease. So a lock period for a very severe disease is ethical unacceptable, and therefore is mostly they have alternative programs, or they allow the drug on the market for a specific period, and then they will make the defined decision. But there are still difficult questions, because when a patient is also on the therapy, it's hard to withdraw it.
Okay.
And I have to make a little correction. I said 60,000 euros. It's 80,000 euros.
Is that 80? Okay. All right. Thank you for that. 80,000 euros.
Yes.
Okay. So that would be roughly the threshold that would be used. And are pharmacists very much involved in doing the health technology assessments at SIM? Or would it be mostly health economists and physicians and university researchers?
No, it's a combination. If you look at the national level, there's a board, and in this board are physicians, ethical persons, but also pharmacists, legal persons, and they all look together at the pricing and the cost effectiveness of the drugs, and pharmacists are definitely involved in that. And then on a more clinical level, in a hospital, for example, a pharmacist is really involved in making choices with respect to the formulary of the hospital, which drugs can be prescribed and which can be prescribed, and also involved in the buying of the drugs, and also thinking together with the physician and the management about how can we influence the volume of the drugs prescribed.
Okay, all right. Understand. That's perfect. Moving on to the next part, which is a recent case study. You've already mentioned one in rheumatoid arthritis, which sounded very interesting when you discussed the second phase of the 4 life cycles of oligopoly, and you mentioned etanercept, rituximab, and adalimumab. I was wondering whether we could maybe discuss this in a little greater detail, maybe just to provide listeners a better understanding. So are these 3 drugs still in the oligopoly phase, or have they already moved into the?
It's funny. They've now also entered the period of the biosimilars, and therefore I think these drugs are nice examples. But these are the first expensive drugs going perfectly in the cycle. This first for monopoly, as you see with infliximab, which is an intravenous system. Then etanercept came. Now there were some therapeutic indications. They said, okay, I prefer subcutaneous drugs, but so at that moment there was we were slowly moving from monopoly to oligopoly, and then Humira entered the market. Adalimumab, there was a real oligopoly, and it's very nice to see that if you applicate then a preference policy, you really reduce price with a huge percentage. But then 3 years ago, the etanercept biosimilar and the infliximab biosimilars came in the market, and then the price really went down, as these drugs are then in the 3rd phase of the pyramid, and that's the phase of the first entrance of generic drugs. And I really think that in 2 years' time, the price of the drugs will decrease far more, as also then adalimumab biosimilars introduced. So then we have all the expensive drugs in biosimilar world, and I really think that then the price will reduce with 70 to 80%.
Wow!
And these are very expensive drugs. For example, when they entered the market, there were drugs of 15,000 euros a year, and roughly estimated when when the first drug was in the market, infliximab, you paid 15,000 euros. After 2-3 years, the competitors came. The price decreased roughly to 11,000 euros. But now, when the biosimilars came, you can really say that the price is now only 6,000 euros. So it went from 15 to 11, 12 to 6, which is a huge decrease.
It's a considerable decrease in the period of time. How long did the drug spend in the oligopoly phase? Was it 3, 4, 5 years?
Even longer, roughly from 2003 to 2015, so 12 years.
Oh wow! Okay. Okay. And then each phase has been quite fast afterwards.
Yeah, I think then the period of the first entrance of the biosimilar is from 2015 until 2020, I think, so for 5 years. And after 2020, I expect that the market of these expensive drugs totally changed.
Okay. Okay. All right. I understand. And the outcomes that patients have been experiencing during these different phases, have those been monitored at all in the form of a registry, for example, in monitoring patient-reported outcomes or clinical outcomes in rheumatoid arthritis?
Yes, in the Netherlands and also in other European countries, we have registries for rheumatic diseases, and they measure on one hand the dispensing of the drugs and the different dosages, but also the measured disease outcomes. In rheumatoid arthritis, you have the so-called DAS scores, the disease activity scores, indicating the extent of the disease activity.
Okay.
And so, for example, in the Netherlands, the DREAM database is a large database of these drugs with both medication content and also the disease activity content.
Okay, all right. Some countries have experimented with things like risk-sharing agreements. I think in the UK there's been some use in that, multiple sclerosis. In Italy there was also some use of risk-sharing agreements or outcomes-based reimbursement in oncology. Has it in Netherlands experimented at all with?
Yeah, there were some experiments with it, but I must say that I'm against this risk-sharing model because it's just a recalculation of the price reduction. So a drug manufacturer knows roughly the effectiveness of the drug, and for example, when a drug is effective in half of the patients, they just calculate how much price the drug will cost or reduction should be paid in order to compensate the drugs they have to give a rebate on it because due to the ineffectiveness.
Okay.
So,
right.
And it's a lot of administration. It's also delivering data directly, unstructured, to the pharmaceutical industry.
Mm-hmm.
So, I have a doubt on this system because there's a lot of administration, and in the end, it will not reduce the price. It's nice from a marketing point of view because you, as a manufacturer, you can say, if my drug is not working, I will give you money back. But in the end, for example, when a drug is effective in half of the patient, the price is doubled, and then it's easy to say that you give your money back when it's not working because you have already calculated in the risk of non-response.
Okay. No,
And I think you have to be realistic. As long as we decide as Western world that manufacturers of pharmaceutical preparations are on the stock market, they would like to have as much as profit as possible. You can't blame them because they're on the stock market.
Yeah.
So they will always calculate a pathway which is best for them on a financial perspective.
Absolutely. Got you. So, Dr. Bart, I'm just reflecting on everything that you've said, and I think we've had a great conversation. We started off by speaking about the structure and the delivery of the healthcare system in the Netherlands, and you very kindly shared how expensive medicines compared to cheaper medicines that were how they are handled, and the full life cycles of the drug, which is a very unique approach to managing drug pricing during its life cycle. I thought that was very interesting. You also spoke about the applied pharmacoeconomics, and I'm sure listeners will benefit a lot from the conversation that we had there. And then also the recent case study, which we focused on rheumatoid arthritis, and you kindly shared the experience that over from 2003 to the present, rheumatoid arthritis drug prices have reduced between 70 to 80%,
Yes.
from 15,000 euros per year to about 6,000 euros per year. So that's a considerable decrease. So I think listeners will definitely benefit quite a lot from what you've shared today. Are there maybe other thoughts that you'd like to share, Dr. Bart, before we conclude today's webinar?
Oh, as this lecture is for pharmacists, I can say that pharmacists really have an important role in cost-effective drug use. And that is on two hands. On one hand, it's influencing the price, for example, with preference policies and helping to introduce biosimilars. But there's even a more chance in also decreasing the volume, so the amount of drug which is prescribed. And you can have an influence on when people start with the drugs, which dosage is used, but also improving the way patients are using their medication. We all know that a lot of patients are non-adherent, and you can help to make people more adherent. We already also know that if you combine some expensive drug with food, you need less medication. So there are a lot of targets which you can target as clinical pharmacist or pharmacist to improve the drug effectiveness of the drug, and taking into account that drugs are becoming expensiver and more expensive. I think our chance as clinical pharmacists, besides medication safety, of course, is also that we have a real reason to be there as experts in the field of pharmacotherapy and HTA in order to also have realistic prices for the drugs.
Those are very thoughtful concluding remarks, Dr. Bart. So if listeners have any follow-up questions, what would be the best way for them to reach you?
I think by mail.
Okay. All right.
And probably you can demonstrate it with my email address then.
Okay, no problem. I'll be happy to provide listeners with your email address if they have any specific questions. So, Dr. Bart, again, once again, thank you very much for your participation today. Really appreciate it.
You're welcome. I did it with pleasure.